All right, hi everyone. I'm Allison Babish. I'm happy to be giving this talk for you guys. We're gonna move along here because we got a lot of material to cover and I know you are almost done. So we're gonna be looking at alignment and movement disorders, external and internal disorders of the eye, and trauma. So you have two eyes for a reason. That's so that they can work together so that they can try to give you depth perception or binocular vision. So when your eyes are perfectly spaced out and they hit an object of interest, they perceive it at a bit of an angle, and that allows you to have depth perception. The images comes into the eye and back to the visual cortex of the brain. When your eyes are misaligned in any way, then that ruins this perfect system. And in children, often then you develop suppression, where at least one eye is not seeing the image the same as the other eye. And it may block the vision, and that chronic understimulation of the visual cortex can result in amblyopia. Strabismus does not equal amblyopia. Strabismus is misalignment of the eyes. 4% of children in the US have it, 1% of adults, and it's one of the leading causes of amblyopia. Amblyopia, the layman's term for that, is lazy eye, and this is a decrease in vision of the eye that's caused by a pattern of vision deprivation, so an eye that doesn't see as well. So strabismus can cause amblyopia. Severe amblyopia could cause strabismus. Sometimes it's hard to figure out which one came first. But this is the most common cause of visual impairment in children. The prevalence is 1 to 4%. So with amblyopia, it actually, most people think of it as unilateral, but it can be bilateral. The causes of it, if you have bilateral high refractive errors and the child is not put in glasses at a young age, then they may not see as well out of both eyes, even when you put the glasses on them. Other causes are anisometropia, so if you have a big difference in prescription between the two eyes, then the eye with the higher glasses prescription often doesn't see as well. Strabismus, so if one eye is chronically misaligned, then it doesn't develop as good a vision. And then something that causes stimulus deprivation like a cataract. The treatment is to eliminate the sensory obstruction, so if there's a cataract, remove the cataract, correct the significant refractive error, and then force the use of the poorer eye. And this is typically done with patching or occlusive therapy, but you can also use pharmacologic penalization such as atropine, and there are studies being done right now looking at binocular video games, but this is still in the trial period. Types of strabismus. So there are typically 3 categories of strabismus: aphoria, tropia, or intermittent tropia. So aphoria, when you look at a patient with aphoria, their eyes are going to look straight to you. But if you cover up one eye, then you can see a little bit of a movement of the eye. Tropia, it's a manifest deviation. You're going to see it. It's obvious. So the eye is constantly turned. And then intermittent tropia means sometimes the eyes are straight, sometimes the eyes are misaligned. So in terms of the types of strabismus, esotropia means crossing inward of the eyes. There's a lot of different types of esotropia. Pseudo-Strabismus is very common. We'll talk about that in a second. Infantile is when the onset is before 6 months old. It's typically a constant deviation. This baby in the picture here has infantile esotropia in the top picture, and that requires surgery, usually at a young age. Accommodative esotropia, typically the onset is a little bit later, usually around 2.5 years old, and these children have a high hyperopic refractive error, and when you put them into their glasses, their eyes are then straight. So if you look at the picture here, this girl's eyes are crossed, and then you simply put her in her glasses, and now her eyes are straight. There are other acquired forms of esotropia, and there are incontinent things like a 6th nerve palsy. Those are rarer. This baby, it looks like they have a right esotropia. But when you look at the child more closely, you can see that the head is turned a little bit to the side. And when you look at the pupils, the light reflex is right in the center of the pupil of each eye. So you know the eyes are straight. That's an example of pseudo-strabismus. And usually you'll have parents come in asking about this at young infants. Usually as kids get older, they kind of grow out of it. It's more common in Asian population. So you can see here with this child, if you simply pinch the skin together, the eyes are going to look straight, but usually parents and kids don't like it when you do that, so don't do that. But it does demonstrate that the eyes are actually straight. But typically these kids have a wide nasal bridge, wide epicanthal folds, and then they appear worse in side gaze. And when in doubt, refer to an ophthalmologist. So I don't want you to assume that they're all pseudo-strabismus. If you think there is a true crossing, send them so that we can check it out. Exotropia, that's turning out of the eyes. There's a lot of different types of exotropia. Infantile is onset before 6 months old. These can be associated with neurologic or craniofacial disorders. So if you have a young child who has a constant exotropia, refer them quickly so that we can get them evaluated. There are acquired forms. The most common kind of acquired or older age onset is intermittent. That means that the eyes look straight sometimes, and sometimes they're turned out. And often with exotropia, you'll see that it alternates between the two eyes. Another common form of exotropia is convergence insufficiency, and this is when there's an exotropia turning out of the eyes when they're looking up close. These kids will often complain about blurred vision and double vision at near. Double vision in a child is never normal, so we always want to be seeing those patients. But there are actually eye exercises that you can do to treat convergence insufficiency. This is a demonstration of cover testing. So you get a pretty good idea of like a manifest or a tropic deviation when you just shine a light on a child's eyes, but if you truly want to see if there's a misalignment, cover test is the best way to diagnose it. So orthotropia means straight eyes, so these eyes look straight. You cover up one eye and the eyes remain straight. You cover up this eye and the eyes are going to remain straight. In exotropia, the right eye looks like it's turning out. Then you put the cover over the straight eye, and the right eye turns inward, and then the left eye will also turn in the same direction. So now when you take the cover away, now you have a left exotropia. Esotropia. So here the left eye is straight and the right eye is turned in. You put the cover over the straight eye, and then this eye moves to become straight, and this eye also moves, so now you have a left esotropia. And hypertropia means a deviation upward. So this eye is deviated up. You put the cover over the straight eye, and then this eye moves down to become straight, but then this eye goes down. So is it a right hypertropia or a left hypotropia? Same thing, doesn't matter. This is a video of intermittent exotropia on cover test. So you see the movement starts to build up the longer you do the cover test. And it's between both eyes you see that movement. And then she corrects it on her own. And she corrects it on her own. So that's very common with intermittent exotropia, that the parents will say, you know, they're daydreaming or they're sick and the eye's wandering out, and I tell them, you know, look at me or snap my fingers, and they'll bring it back together. Or you'll see them do a lot of blinking and then it'll bring the eyes back together. So the treatment for strabismus, the goals of strabismus surgery are to enable or restore binocular vision in children. So we don't consider this a cosmetic thing, and this is typically covered by insurance because it is improving their visual function. In adults, often they will have double vision. So a goal is to eliminate diplopia and restore fusion and normal ocular movements. The other thing is that sometimes with strabismus, kids and adults will adopt abnormal head posture, so you want to try to eliminate that. So we have an order of steps that we follow with strabismus. First is correcting errors of refraction, so putting in the correct glasses. Then treating amblyopia to try to get the vision as good as possible in each eye. And then realigning the visual axis with prisms or surgery. If you go out of order with it, it doesn't usually work well. So if you operate before getting the vision better in the amblyopic eye, the eye is much more likely to wander again. When do you refer a patient with strabismus? So intermittent strabismus is really common in young infants, especially kids who are born preterm. So you usually want to reassure the parents that it's likely going to go away, but you want to keep an eye on it. After a few months old, if it continues to be intermittent, watch it more carefully, but if it's persisting, especially by a year old, you need to refer them. If it's a constant strabismus, it's never normal. You want to refer them right away because that needs to be treated earlier. And then amblyopia is easier to treat the younger we catch it, and it's very difficult to treat after 8 years old. Now that doesn't mean if a child comes in after 8 years old and they've never been in glasses, they've never done patching therapy, we're not going to just send them away. We're going to work with them. And often we can pick up the vision a little bit with treatment, but often we're not getting them back to 20/20. Nystagmus is a rapid involuntary back and forth movement of the eyes. Typically it's horizontal, but it can be vertical or it can be torsional. It can worsen in certain gazes, so you have probably all seen looking over an end-gaze nystagmus. That's a very common one. Nystagmus can be congenital or acquired. It can be hereditary, so if there's a family history of nystagmus, you're less apt to work it up. There can be ocular causes, so if they have some sort of structural abnormality of the eyes that prevents them from seeing well, they may develop nystagmus. Albinism, it's very common. Neurologic disorders, syndromes like Down syndrome, it's more common. Certain medications and drugs can cause it as well. Usually there are no symptoms with it, so some people worry that with nystagmus, their child is seeing the world moving back and forth, but that's not the case. Usually they aren't aware of anything being different. If a child, like an older child or an adult comes in and they're seeing things moving, that's a bad sign, and you want to work them up right away. So they need to be seen by an ophthalmologist, and sometimes they need to be seen by a neurologist. The only time that there is no treatment for nystagmus. But the only time that we're operating is when there's a large face turn. So sometimes there's a null point where the person will turn their head in order to access a null point where the nystagmus decreases. So if they're doing that consistently, you don't want to have them turn their head for the rest of their lives. So we can move the eyes over with strabismus surgery so that their null point is then straight ahead. External disorders of the eye. Conjunctivitis, our favorite topic. So viral, which is we call pink eye, is a very common form of conjunctivitis. It usually starts in one eye. It'll be copious, watery discharge, pink-looking eye, and then it can spread over to the other eye. Often everyone in the family is getting it, or there will be someone at school who had it as well. You want to check for a preauricular lymph node. Often they'll have had a history of a URI. Bacterial is very rare. It's usually much more severe. This you're going to see a purulent discharge, and the eye's going to look quite red and angry. And usually this is just in one eye. Allergic is very common, and the hallmark with that is itching. So if someone comes in with goopy eyes and they say they're itching a lot, that's likely allergies. And also if they have a history of seasonal allergies and that's their season for acting up, that you've pretty much got your answer. Chlamydial is more common in the neonatal population, but if you have a child coming in who's having persistent conjunctivitis and you've tried different treatments and it's responding, maybe you're missing something. Maybe there's a chlamydia diagnosis. Toxic or chemical, usually there's a history of some sort of spill or exposure, and then immune conditions, and those can result in subconjunctival scarring. So kids with certain kinds of autoimmune conditions, we're watching them very carefully for any signs of chronic changes. So the treatment, bacterial, yes, you do want to treat with antibiotic drops or ointment. Viral is a viral process, just like your guys' pet peeve is, URIs getting treated with antibiotics. Our pet peeve is pink eye getting treated with antibiotic drops because it's a viral process. So the antibiotic drops aren't doing anything. Now that being said, viral conjunctivitis lasts a week or two, and if it's behaving atypically, then you may want to put an antibiotic drop on there. But in general, it usually just has to run its course. For allergic conjunctivitis, cold compresses can help, but usually anti-allergy drops and antihistamines will work. So you want to treat the systemic allergies as well as the ocular. So mast cell stabilizers, antihistamine, eye drops are helpful. Sometimes we have to use steroids as well. Chemical conjunctivitis, so you need to irrigate it, make sure that the pH gets back to 0, and sometimes we have to treat that with steroids. Sometimes if there's a chemical burn to the cornea as well, we're putting them on antibiotics. And then immune conjunctivitis, sometimes they require steroid drops. Anybody who we put on steroids has to be monitored very carefully for glaucoma. Ophthalmia Neonatorum, so some clues with that is the age of onset. So if you have conjunctivitis within the first day, then it's more likely to be chemical, and that would be caused by silver nitrate, but most places are not using that anymore, so we're not running into that problem. If it occurs within 2 to 4 days, it's more likely to be gonococcal, but bacterial can occur at any time, and you think of more of the common bacterias. Chlamydia is very common, up to 40 to 70% of cases. Pseudomonas would be a very aggressive form of conjunctivitis, and then HSV is rare, and it can occur after 1 week old. The treatment, children receive prophylaxis with tetracycline or erythromycin ointment now typically, but if a child develops conjunctivitis, you want to isolate them, perform gram staining cultures, identify the source and the carriers, and treat them with the appropriate medication. So with chlamydia, you have to treat with systemic antibiotics because of the associated pneumonia, and you also want to test for other STDs and treat the parents. Same thing with gonococcal. Cellulitis. So there's 2 different kinds of cellulitis. There's preseptal and orbital. With preseptal, that is occurring anterior to the septum of the eye. Orbital is posterior to the septum of the eye, and that's much more severe. So with preseptal, the signs are eyelid edema and erythema, and it can extend onto the eyebrow and forehead. Orbital, much more severe signs, so if the child has proptosis, limited ocular motility, diplopia, pain with eye movements, globe inflammation, decreased vision, abnormal pupil reaction to light, or systemic symptoms of fever, headache, orbital pain, lethargy, those are all signs of orbital. That's much more serious. With preseptal cellulitis, the causes can be from trauma with direct inoculation, could be from a URI or an ear infection, or a spread from adjacent structures from the skin and sinuses, and that could include impetigo or HSV. Treatment is, your common bacteria are typically the cause, and treat it with PO antibiotics, except if the child is under a year old, or if they're showing signs of systemic illness, then you may want to hospitalize them for cultures, checking the eyelid and the blood, CBC, CAT scans of the sinuses and orbits, and possibly treating them with IV antibiotics. Orbital cellulitis, the causes are usually ethmoid or frontal sinusitis. It can be traumatic. When the child is less than 9 years old, it's usually a single aerobic bacteria. When they're older than 9 years old, then it's more typically multiple pathogens. The differential diagnosis includes pseudotumor and orbital tumors. The treatment is to image with CAT scan to look for sinusitis or a subperiosteal abscess. If there's sinusitis, you're likely going to have to get ENT involved. Other complications include cavernous sinus thrombosis and intracranial extension. This is showing an image here, and so you can see with this globe that the optic nerve was right here, and then the lateral rectus to the side, and the medial rectus is displaced temporally, and that's because there's a subperiosteal abscess here, and that needs to be drained. Chalazia or Styes. We usually use the terms interchangeably, but there technically is a difference. So a chalazion is a clogged lid oil gland, whereas a stye, also called a hordeolum, is a bacterial infection of the lid oil glands. And with styes, there's 2 types. There's external, that begins at the base of the eyelash, and internal, which occurs inside the eyelid, and the symptoms are a small red painful lump. Risk factors for chalazia include blepharitis, prior styes, rosacea or seborrheic dermatitis, and diabetes. The mainstay of treatment is warm compresses. I don't really care what you use for a warm compress. You can do a washcloth, soak it in warm water. You can do a tea bag. You can do a hard-boiled egg in a sock. You can do rice. I've heard it all. Whatever it is, warm compress on there. And do it numerous times a day. And if you can try to do it for a few minutes, I know it's really hard on the toddler who's running around, but that's the best thing. If you see that they have lots of crusting and goopiness to the eyes, then lid hygiene with baby shampoo. You just take a dime-size amount, lather it up on a washcloth, have them close their eyes and scrub the eyelids and rinse it off. Do that once a day. Antibiotic ointment sometimes. If it looks like it's red and maybe infected, then an antibiotic ointment can help with that, but it's typically not going to treat the underlying chalazion. PO antibiotics, sometimes the stye will turn into a cellulitis, and so you have to treat it with an oral antibiotic. That usually takes care of the cellulitis, but often you're still left with the chalazion. Blepharitis, if someone seems to have really crusty eyelids and they're getting recurrent styes over and over again, then sometimes you have to put them on an oral antibiotic, even for a couple of months, and that can help wipe out the bacteria causing the blepharitis. I like to put people on flaxseed oil. It seems to work really well for kids who are getting recurrent Chalasians. It just helps keep the oil glands open. It's hard to find a flaxseed oil that kids like to take, though. They do have flavored gel packs, and those tend to work well, but they're a little hard to find. And then if all else fails, we can drain them surgically, but you have to take them to the operating room under general anesthesia, so we try to avoid that for a stye if possible. Nasolacrimal duct obstruction, this is really common in infants. So the tears are produced in the lacrimal gland, which is under the upper eyelid, and then the tears fall across the eye, and there's the puncta in the upper and lower eyelids. The tears travel down through the canaliculus into the nasolacrimal sac, and down into the nasolacrimal duct, into the inferior meatus, and back down the throat. If there's an obstruction somewhere along there, then the eye will become watery, so lots of watering and sometimes discharge from the eyes. It's typically due to a membrane obstruction down at the bottom of the nasolacrimal duct. It occurs in 2 to 6% of newborns. It can be bilateral in a third of the cases, and you can have a superimposed conjunctivitis. Tearing in infancy, so nasolacrimal duct obstruction is the most common, but there are other things that can cause tearing. So punctal agenesis, that's where they're not born with puncta. It really doesn't go over well when I take a kid to the operating room for nasolacrimal duct obstruction and you get in there to probe and realize there's no puncta. So it's nice to diagnose that before you get into the operating room. It's very difficult to treat, though. Dacryocystoceal looks different than a nasolacrimal duct obstruction. So with a dacryocystoceal, you're going to see a blue raised lump. It can be bilateral. You can see these dacryocystoceals here on the scan. The problem is if it's bilateral, it can block the airway for these nose-breathing kids. A fistula of the lacrimal sac, so it is possible that they'll have a separate drainage area. You look lower than the puncta and you can find a fistula. A canalicular laceration, if there's a history of a dog bite, they seem to always find the nasolacrimal duct system. This baby, you don't want to miss that. So that eye is watery, but it also looks very different. So it looks kind of cloudy and large. That's a congenital glaucoma. So nasolacrimal duct obstruction, usually they will resolve by a year-old with non-surgical management. And we want you to be encouraging the parents to do compression numerous times a day. You can also use an antibiotic ointment, but that's not going to treat the underlying condition. It's just going to help with the recurrent conjunctivitis that they get. Surgical at a year-old, then we'll probe. Sometimes when you get in there, you realize there's not a membrane and it feels tight, and we have to put in a silicone stent. If the child's older than 2 years old, often we're just going to put in a stent anyhow because usually the probe doesn't take care of it. And they may need a DCR, which is a much bigger surgery. So this is how we encourage you to do the massage, which is really a compression. So what you're trying to do is pop open the nasolacrimal duct. And that's not like taking a washcloth and slowly massaging around there. This is actually bracing the head so you get some support, and then starting right in between the upper and lower eyelid, push against the nose and push down. And it's pretty hard, so the kids aren't going to like it that much. You're not hurting the child, it's just not a comfortable massage. I usually recommend doing it like on newborn infants with every feeding, so you're really being pretty aggressive with the massage, and usually that will take care of it. I had it with my infant daughter, and I really went to town on it. It was gone within a week. She was bruised, and she'd go like this every time I went to feed her, but she did not have her duct probed. Ptosis. So with ptosis, it's a droopy eyelid. There's two types. You can have congenital or acquired. The acquired could be myogenic, so due to myasthenia gravis, progressive external ophthalmoplegia. neurogenic, like a Horner syndrome or a third nerve palsy. You don't want to miss those, or a mechanical cause. Complications, so if the eyelid is drooping and weighing on the cornea, the front clear surface of the eye, it can actually change the shape of the cornea, and that can cause astigmatism. And if you have astigmatism of one eye and not the other, that can lead to amblyopia. So you need to be on top of these kids to make sure they're getting routine eye care. The treatment is surgical correction if it's blocking the visual axis or causing a chin-up positioning. Horner syndrome, this is a triad of ptosis, meiosis, and hydrosis. Don't want to miss that. There are a lot of different things that can cause it, but it's a lesion somewhere in the sympathetic pathway. The thing that people worry about a lot is neuroblastoma. Orbital hemangioma, so just like you can get a hemangioma anywhere on your skin, if it develops on the eyelids, particularly on the upper eyelid, that can cause visual impairment. So just like ptosis, that hemangioma rests on the eyelid, changes the shape of it, can induce astigmatism, and that can cause amblyopia. So some of these you can just monitor, but some of them we are more aggressive about treating them if they're causing vision abnormalities. Internal disorders of the eye. So congenital glaucoma. Glaucoma is where you have high eye pressure, and that pressure of fluid inside the eye, it would cause like a balloon to stretch, but the eye can't stretch much, and so instead it causes thinning or damage to the walls of the eye, and the optic nerve is what gets damaged, and that creates a characteristic cupping appearance to the optic nerve, and that can cause loss of peripheral or side vision. And the vision loss is permanent, so you want to try to catch this early before there is vision loss. Glaucoma is very rare in children. It's very common in adults, but you don't want to miss it in a kid. The nice thing about congenital glaucoma is typically they'll have other symptoms. So there's a triad of epiphora, so watering of the eye, photophobia, light sensitivity, and blepharospasm, blinking of the eyelids. They also can have corneal clouding and ophthalmos, or an ox eye. Whereas if a child develops it as juvenile glaucoma, so not when they're within the first few years of life, then they're typically asymptomatic like an adult, so you have no idea that this process is occurring. And it can only really be caught on routine exam, though there is a family history of it, so that can give you a clue. There's also secondary glaucomas, ocular anomalies, and systemic disease like Sturge-Weber can cause glaucoma. Childhood cataracts. So the concern is with cataracts, you can develop it in one eye or both eyes. If you have it in just one eye, you can get amblyopia. You want to look for signs of systemic disease and associated ocular abnormalities. The management depends on how significant the cataract is, so not every single cataract has to be surgically removed. Some of them are very small or not very dense, and so they're not considered visually significant. But if they are visually significant, you want to have them removed early, and then after that, we're managing refractive error and amblyopia. Cataracts can be a sign of systemic diseases. So in this picture, you can see an oil droplet cataract, and that's a sign of galactosemia. Here you can see on the cornea these lines. Those are called verticillata, and that's in Fabry disease. Wilson's disease has a sunflower cataract, and myotonic dystrophy has a Christmas tree cataract. So the workup for cataracts, you want to examine both appearance because sometimes they will also have mild cataracts, and you'll know that it's a hereditary thing. But in infants with bilateral cataracts, you have to worry about torch, so working up with torch titers, checking a VDRL, checking the urine for reducing substances, checking a calcium and phosphorus, ferritin levels, and cholesterol. Mevalonic acid, urine amino acid levels, G6PD, and then you also have to consider trauma. So a blunt trauma can cause a cataract in one or both eyes. So typically ophthalmologists are not the first ones to diagnose this, they're getting referred to us. So that's why every single visit for a newborn through their well child checks, you're checking for a light reflex. So you're looking for an asymmetry of the red reflex of the eyes. If it's dull or blunted in both eyes, maybe they have a cataract of both eyes. But you want to refer them to be evaluated. So when you think about an abnormal red reflex, you think of leukocoria, white pupil, and you worry about retinoblastoma. So an abnormal pupillary light reflex can look white or tan. It depends on the lighting conditions and depends on the direction of gaze. So you might refer a patient for an abnormal red reflex, and they come to see us and we say everything's normal. That's fine. We'd rather have tons of normals and not miss the one retinoblastoma. And it may have just been that the child had their eye turned while you were checking the red reflex, or maybe the lighting wasn't right, something like that. So in this child, you can see that it looks like they have an abnormal white reflex, a white reflex, and then a normal reflex. And that's just photo editing. So you also have to worry about the camera and the automatic red reflex fix. So make sure that that's turned off on the camera. So when the parents come in with those pictures, you check and try to see if you're seeing something more than just once. So retinoblastoma occurs 1 in 13,000 live births. 25% are bilateral, 40% are heritable, 60% are sporadic. The age of diagnosis, if it's bilateral, more likely under 12 months, unilateral, more likely greater than 15 months. 95% of cases are diagnosed before 5 years old, but they can be diagnosed as late as after 10 years old. This is an autosomal dominant trait and then an additional sporadic deletion on top of it. So it's a recessive gene and it's an absence of the tumor suppressor gene on 13q14. In the heritable cases, there's one germinal mutation and one somatic mutation. Typically, the retinoblastoma will be bilateral, multifocal, so numerous lesions in the retina. And they are at risk for secondary tumors. In sporadic, they have 2 somatic mutations, and that's usually unilateral and unifocal. The clinical presentation, so the number 1 sign is leukocoria, but they may present with a strabismus, they may present with a persistent red eye or a hypopion, which is a collection of white blood cells in the anterior chamber, so the front part of the eye will look like there's like a white layer on the bottom of the anterior chamber. You can see here in the pictures that there are, this is seeding of, they're all different little tumor spots. This one you can see the giant tumor behind the lens of the eye in the bottom picture. You want to refer this right away. When they come and see the eye doctor, we're going to be doing a dilated eye exam, checking an ultrasound of the eye and checking a CAT scan and looking for calcifications. So you can see the calcifications showing up on the scans there. Differential diagnosis for leukocoria, it could be a cataract or PHPV. Coats disease, toxo, a coloboma, myelinated nerve fibrillary, Morin glory disc anomaly, retinopathy of prematurity, child abuse. So lots of different things, but all of them need to be evaluated. The treatment for retinoblastoma, the cure is actually 98% with cases that are taken care of in a timely fashion. We are still enucleating for advanced cases. Some are treated with chemotherapy, and they do have interventional radiologists can go in with intraarterial chemotherapy where they're threading all the way up into the eye and injecting the chemo, which is pretty cool. For cases, especially when they're bilateral, so you don't want to take out both eyes, the eyes that have more focal areas of involvement, you can try to do localized treatment with lasers or cryo or plaques. And then they're at risk for secondary malignant neoplasms, and they can occur up to 30 to 40 years later. Osteosarcomas are the majority. You can also get a cutaneous malignant melanoma. There's been questions about the role of radiation therapy in treating the tumors. So if these people are at high risk of developing more tumors and you give them radiation treatment, is that increasing their risk? This is still being debated. Papilledema. So papilledema is optic disc edema secondary to elevated intracranial pressure. So you can see the picture of the normal optic nerve here, and then a picture of a swollen optic nerve with hemorrhages. That means that there's some acute process going on. The etiology can be hydrocephalus, mass lesions, or idiopathic intracranial hypertension, which can also be called pseudotumor cerebri. Signs include a firmness or distension of the fontanelles, nausea, vomiting, headaches, transient visual obscurations, esotropia from a concomitant sixth nerve paralysis. You want to work them up with a dilated eye exam, then check brain imaging, then do a lumbar puncture for an opening pressure and make sure that they're positioned correctly for that opening pressure, and check the CSF. Retinopathy at prematurity. So this is when babies are born prematurely. The retinal vessels are not fully complete until 40 to 44 weeks gestational age. So while the vessels are growing out after the baby has been born, neovascular vessels can occur, and that can cause retinal detachments and blindness. So we screen the babies in the NICU and even after they get discharged to make sure that the retinal vessels are growing out appropriately. So we're going to do exams on them if they're born under 31 weeks gestation, if their birth weight is less than 1,500 grams, or if their birth weight is 15 to 2,000 grams, but they're on oxygen or have an unstable course. The first exam is at 4 weeks after birth or the gestational age of 30 to 31 weeks, whichever is later. Ocular trauma. So corneal abrasion. Scratched cornea is super painful. The eye will be watery and red, and they'll be quite uncomfortable. You diagnose it by putting a fluorescein drop in the eye and see it light up bright green. The treatment is topical antibiotics, and we want to see them within either the same day or the next day, just to make sure that there's not a deeper laceration or a foreign body. A corneal foreign body is going to have similar symptoms, but they're not going to resolve with an antibiotic. So if you have someone who you can see has these linear streaks with the fluorescein, that's a foreign body stuck under the eyelid that's just scraping it every time they blink. So that needs to be removed. A blowout orbital fracture, fracture to the bony wall of the orbit, typically the floor. The symptoms will be a swollen lid, diplopia, nausea, numbness to the cheek, nose, or teeth. The workup, you want to do an eye exam to check the motility and assess for entrapment, and then do an x-ray or a CAT scan to evaluate for entrapment. You can see here on the scan that the orbital contents are herniating down into the sinus. If there is no entrapment, then can treat with ice packs, decongestions, no nose blowing, possibly steroids, possibly antibiotics. If it's entrapped, it needs prompt surgical repair, because especially if there's a slip door fracture, then the muscles are trapped and cut off so that they're not getting the blood supply, and that muscle can die. So even after you fix the fracture and restore the muscle to its normal place, it's not going to function normally. A hyphema is blood in the anterior chamber of the eye. It can be due to trauma, it can be due to other things. So if there's no history of trauma, you want to work up for things like JXG, leukemia, bleeding disorder, or retinoblastoma. Any person who comes in who's African American with a hyphema, you have to check for sickle cell unless you have a known family history. And usually it will resorb on its own, but you want to put a hard shield on there to prevent them from bumping their eye again and limit their activity. You want to monitor the intraocular pressure, because you can have pressure spikes that could cause glaucoma, which can cause blindness. And you want to have a much lower threshold for going in and draining the blood if the patient has sickle cell disease or trait. And that's it for my presentation. This is my daughter, who also, with the nasolacrimal duct obstruction, had an intermittent exotropia, and I started patching her at like 1 week old. But she grew out of it. I have a few questions that we can do. Nasolacrimal duct obstruction can be differentiated from congenital glaucoma, and I don't have this set up for you guys to respond, so you can just, oh, they do? Perfect. Okay, great. So the presence of lacrimation in nasolacrimal duct, but not glaucoma. The occurrence of nasolacrimal duct obstruction in younger and glaucoma in older infants, clouding and enlargement of the cornea in glaucoma, but not nasolacrimal duct obstruction, or the mode of inheritance. Okay. So yes, you're correct. So clouding and enlargement of the cornea in glaucoma will occur, but not in nasolacrimal duct obstruction. And then the differential diagnosis of a white pupillary reflex includes all of the following except A, retinoblastoma, B, toxocariasis, C, Coates disease, D, optic nerve glioma, or E, PHPV. Very good, an optic nerve glioma. So with that, it's the lesion is retrobulbar to the optic nerve, and so it's not going to show up in the eye, so that won't affect the white reflex. And that's it.